Laparoscopic Entry Techniques by Dr. Carlos Sandoval and Kennedy. The baseline peritoneal pressure ranges from 5 to 7 millimeters of mercury in adults with a healthy BMI, with optimal insufflation pressures typically set at 10 to 15 millimeters of mercury. The baseline pressure in morbidly obese patients ranges from 9 to 13 millimeters of mercury, requiring careful adjustment of insufflation settings. Obesity is linked to increased entry attempts, longer operative times, difficulty identifying landmarks, and higher conversion rates to laparotomy. Pre-operative assessment of body habitus is important for planning trocar placement. It's especially important to evaluate the umbilicus in relation to landmarks like the aortic bifurcation, the ischial spines, the xiphoid process, and the costal margins. Though retroperitoneal vascular injuries are rare, occurring in about 0.3 to 1% of all laparoscopic procedures, their severity necessitates precise knowledge of vascular surface anatomy, especially during midline port placement. The umbilicus is commonly used for initial access due to its central location and proximity to the abdominal cavity. In individuals with a higher BMI, the bifurcation may shift superiorly by approximately 2.4 centimeters in overweight patients and to 2.9 centimeters in obese patients. The inferior and superficial epigastric arteries branch from the external iliac artery and course towards the umbilicus. The inferior epigastric artery is the most commonly injured vessel during laparoscopic entry. Post-operatively, all port sites should be inspected, as a trocar may temporarily compress and mask a vascular injury. Overview of entry points and techniques. First, we'll go through the normal or classic technique. The classic technique is the most widely used. Veress invented the Veress needle in 1938 to prevent damage to organs during removal of fluid from thoracic or peritoneal cavities. The Veress needle has a blunt tip, or longer end, a spring-loaded cannula with sharply pointed external needle or shorter end. Applying resistance to the ends of the Veress needle retracts the blunt tip, exposing the sharp needle. This allows for perforation to the fascia. The blunt end advances automatically, with supposedly no danger to internal organs. Here we demonstrate direct entry of the Veress needle through the umbilicus. The Veress needle provides a tactile sensation of 2 clicks. There's the first, and there's the second. The first click signifies perforation of the abdominal wall fascia, and the second click, the parietal peritoneum. Hasson's technique. Hasson's technique is a popular option due to direct visualization and opening of the peritoneal fascia. It uses a small incision with direct fascia and peritoneum opening, followed by a finger sweep to check for bout or adhesions. Palmer Point. Palmer's Point is located 3 centimeters below the costal margin in the left upper quadrant mid-clavicular line and is used when midline adhesions are suspected. It is not ideal as a working port in pelvic surgery due to its high position. Optical trocar technique. The optical trocar technique uses a bladeless trocar with a 0-degree laparoscope loaded from the distal tip, which transmits real-time images. This technique allows for direct visualization of the abdominal layers. Here we have controlled entry with our bladeless trocar. There you can see the real-time imaging. First, you'll see the subcutaneous fat. There's the anterior rectus sheath, and underlying that, the rectus abdominis muscle and posterior rectus sheath. Now you are in the peritoneal cavity, likely in the fatty omentum. Newton-Jane point. Newton-Jane's point is located at the intersection of 2.5 centimeters medial from the acis and the upper margin of the umbilicus. The advantage to this point is that it minimizes chances of great vessel injury. Right upper quadrant entry. The right upper quadrant point is considered when the umbilical and palmar points are not suitable. It is important to consider the size of the liver when entering through the right upper quadrant. It is a very vascularized organ, and injury could result in significant hemorrhage. The Xiaoming Guan point. The Xiaoming Guan point of Baylor is located halfway between the umbilicus and xiphoid process, then 1 centimeter laterally. Now let's go through the Sandoval technique. Grab an Alice clamp and 2 tau clamps. First, you'll grasp the superior aspect of the umbilicus with the Alice clamp. Then, apply the tau clamps to the lateral borders. Next, inject Marcaine into the umbilicus. The local anesthetic hydrodissects the abdominal wall structures, particularly the nerves, and provides a long-lasting analgesia during and after the procedure. Here is our Veress needle. Here we are applying the CO2 to the Veress needle. Elevate the abdominal wall using all three instruments to increase the distance between the abdominal wall and the underlying viscera. Now we entered the peritoneal cavity with the Veress needle. Here you can see the single-digit pressure of the peritoneal cavity. Thank you for watching.